Welcome to the weekly Neurology Deep Dive. Just a reminder, this is for educational purposes only, no commercial goals, and it's a summary. You really need to read the full original paper for a complete understanding. Today, we're diving into multifocal motor neuropathy based on a narrative review from Muscle and Nerve 2025. Our aim here is to pull out the critical info on MMN clinical features, diagnosis, treatment, focusing on what's practical for neurologists in their daily work.
Okay, let's start at the basics. What is MMN? It's an acquired autoimmune polyneuropathy. It almost exclusively targets motor nerve fibers.
Acquired, autoimmune, motor focus.
Got it. Is it common?
No, actually, it's quite rare. The prevalence is low, less than 1 in 100,000. We typically see it cropping up in middle-aged adults.
And the main thing to look for clinically?
The key feature is this chronically progressive asymmetric weakness. It most significantly affects the distal upper extremities, think hands and fingers.
So weakness in the hands, often uneven between sides. Anything else early on? Well, some patients, maybe up to about 22%, might have minor sensory symptoms, usually in the lower extremities. It's typically subtle, like reduced vibration sense distally on exam.
And diagnostics.
Electrodiagnostic studies are crucial. They often show motor conduction blocks, specifically at sites where nerves aren't usually compressed.
Conduction blocks. Okay. What about labs?
Anti-GM1 antibodies can be elevated, but it's less than half the patients, maybe 30 to 40%.
And treatment.
Immunoglobulin therapy, IVIG, that's the first-line approach. It's effective for most patients in maintaining or restoring strength. But it's important to know, a slow decline long-term is unfortunately pretty common, even with treatment.
Right. So for practical recognition, say in a busy clinic setting, how does this MMN usually manifest? What should trigger that thought?
The asymmetric chronic or sometimes stepwise progressive weakness, that's seen in 80 to 100% of patients.
And usually starts where?
Distal upper limb onset is most common, about 60 to 80%. And it tends to hit the finger extensors more than the flexors.
Okay. Hands and finger extension weakness, lower limbs.
Distal lower limb onset is less common, maybe 15 to 30% of cases.
Any specific triggers or characteristics?
Yes, actually. Worsening weakness with cold exposure, they call it cold paresis, that's reported in up to 83% of patients. It's much more frequent, like 5 to 6 times more frequent in MMN than in CIDP or PMA.
That cold sensitivity sounds like a really useful clue. Anything else distinctive?
The weakness can seem out of proportion to the amount of muscle atrophy, particularly in the early stages. Atrophy does eventually develop in nearly everyone, but that initial mismatch is noticeable.
Interesting. Other signs?
Fasciculations and cramps are quite common, maybe 20 to 60%. Reflexes are typically reduced or sometimes normal.
Any unusual presentations we should be aware of?
It's uncommon, maybe 2 to 8%, but you might see proximal arm weakness at onset or even hyperreflexia in the affected limb segment. Cranial nerve involvement like X through 12 or ophthalmoplegia is very rare.
And you mentioned subtle sensory signs earlier.
Right. Objective sensory findings, mainly that vibratory loss in the distal lower extremities, can occur in up to 22%. It seems more likely with longer disease duration. And importantly, if you do find significant objective sensory loss, especially developing later, you really need to consider MAD-SAM. That's the multifocal variant of CIDP. The median time for those sensory symptoms to show up in patients who got reclassified was around 30 months.
Okay, crucial differential point there. So when MMN is suspected clinically, let's talk electrodiagnostics. What are we looking for?
Conduction block, that's the absolute key diagnostic feature.
And how is that defined, the criteria?
The EFNS-PNS criteria for a definite conduction block are pretty specific. A 50% or greater reduction in the CMEC area across a nerve segment, median, ulnar, or peroneal, with no more than a 30% increase in CMAP duration. And also the distal CMAP amplitude needs to be reasonably preserved, at least 20% of the lower limit of normal, or 1 millivolt.
Okay, 50% area drop, minimal duration increase. What about probable block?
Probable CB has slightly looser criteria. Either a 30 to 49% CMAP-P area drop across a long segment in the upper limb, again with less than 30% duration increase, or you could have a 50% or more area drop, but with more than a 30% duration increase.
How often do we actually find these blocks?
The definite CB is found in, say, 56 to 81% of patients. If you include probable blocks, that goes up maybe as high as 94%. These blocks usually involve short nerve segments, less than 50 millimeters, often found with inching techniques. And they're more common in the upper extremities, especially the median and ulnar nerves.
Does the duration of illness matter?
It seems so. Longer disease duration without treatment is associated with finding more conduction blocks.
Can we use CB changes to monitor treatment?
Not reliably, no. Conduction blocks can actually improve, worsen, or even appear in new segments despite treatment. So it's not a great outcome measure on its own.
Are there other criteria for conduction block?
Yes, the 8NMN criteria exist, but they're a bit more complex for routine clinical use, with different cutoffs depending on using CMP area versus amplitude and considering temporal dispersion. And it's really important to remember MMN can't be diagnosed just on EDX findings. Some experts argue the EFN-SPNS criteria might even be too stringent.
Too stringent, meaning some patients might have MMM without meeting those criteria.
Exactly. Up to maybe 44% of patients with a very typical clinical picture might not show definite or probable conduction block on testing. Blocks that are very proximal or very distal can be technically difficult to demonstrate. And if there's severe axon loss already, that can mask an underlying conduction block.
Interesting. Do those patients without clear CB look different clinically?
They might have less proximal weakness, but otherwise there aren't really clear differences in demographics, GM1 antibody status, or overall clinical severity. You could even have a pure lower motor neuron picture that responds to IVG, presents with distal upper limb weakness, normal CK, normal thoracic paraspinal EMG, and EDX changes only in weak areas, but still no definite CB.
Okay, so conduction block is key, but its absence doesn't rule MMN out entirely if the clinical picture fits. What other EDX features might support the diagnosis?
You might see a mild slowing of conduction velocity, maybe down to 27-33 meters per second, but usually only in the segments that are actually blocked. Elsewhere, velocities are typically normal.
F waves, latencies.
F waves might be absent or prolonged in nerves that have a conduction block. Distal motor latencies can be mildly prolonged in maybe 30 to 40% of patients, but significant prolongation is less common, maybe less than 5 or 10%. Temporal dispersion frequency is variable. You often see reduced distal CMAP amplitudes, which tend to correlate with how long the patient has had the disease. Sometimes these reduced amplitudes can improve quite rapidly with immunotherapy, which might suggest a reversible distal conduction block mechanism.
What about needle EMG?
In the weak muscles, you'll typically see signs of active denervation and chronic reinnervation. Sometimes you might see reduced recruitment, but with normal-looking motor unit potentials, which could hint at a conduction block hiding there without much axon loss yet. But ultimately, the amount of axon loss seems to be a stronger driver of the actual weakness than the conduction block itself.
That makes sense. And what about sensory nerve conduction studies? Are they always normal?
Characteristically, yes. SNAP abnormalities are typically absent, even when you test across a nerve segment that has a definite motor conduction block.
Always.
Well, longitudinal studies suggest some patients can develop reduced SNAP amplitudes later on. This seems associated with having more nerves affected overall and lower distal motor CMPs, but interestingly, not directly with disease duration or GM1 antibody status.
So if sensory findings do emerge,
If you see objective sensory abnormalities developing, especially reduced SNPs, that should definitely prompt you to reconsider the diagnosis. Think about alternatives like multifocal CIDP, MAD-SAM. Some patients initially called MMN get reclassified later when sensory signs appear.
right, okay. Let's shift to labs. How helpful are those GM1 antibodies, really?
They're found in about 30 to 40% of current MMN cohorts, usually the IgM type. There's some debate, but high titers might indicate more severe disease. Data is conflicting on whether being positive or having a high titer predicts a better treatment response.
Can other conditions have GM1 antibodies?
Yes, low titers can be seen in ALS, other neuropathies including multifocal CIDP, and even in some healthy people.
So specificity versus sensitivity.
If you use a high titer cutoff, say 1.4000 or more, the specificity is pretty good, around 93%. But the sensitivity is limited, maybe 50%, meaning a high positive result is supportive, but doesn't absolutely clinch the diagnosis. And low titers don't really help much diagnostically. There are some assays using GM1 combined with galactocerebrosidase, GM1 GALC, which boosts the positivity rate, maybe up to 75%, but you lose some specificity.
Are there any other antibodies worth checking?
Antibodies to things like GD1A, GD1B, GM2 can be found, but probably don't have much clinical significance. The data on antibodies to nodal or paranodal structures like gliomidin or neurofasciin isn't consistently confirmed. Male B antibodies have occasionally been reported in patients who look like MMN peripherally, but also have CNS demyelination or optic neuritis.
What about other lab abnormalities, CSF?
An IgM monoclonal gammopathy is found in about 7% of MMN patients, compared to maybe 2% of controls. About two-thirds of those are also GM1 positive. CK levels can be modestly elevated, maybe 300 to 600, in up to two-thirds of patients. CSF is often completely normal. You might see mild protein elevation, say 50 to 80 milligrams per deciliter, in about 20 to 40% of cases. Interestingly, patients without conduction block are less likely to have elevated CSF protein.
Okay, let's talk imaging. What's the role of MRI or ultrasound in supporting an MMN diagnosis?
Brachial plexus MRI can show abnormalities in 30 to 50% of patients, things like T2 hyperintensity or nerve enlargement. This can be seen in both early and late disease. Contrast enhancement isn't usually very striking.
Any advanced MRI techniques?
Diffusion tensor imaging, DTI, might potentially help differentiate MMN from other lower motor neuron syndromes. Forearm MRI can also show nerve enlargement and changes in diffusion.
Is the pattern helpful?
Asymmetric findings on bilateral cervical plexus imaging are pretty typical in MMN and also in multifocal CIDP, which is different from typical CIDP, where it's usually more symmetric. Less than 10% show asymmetry. Nerve hypertrophy in MMN tends to be less pronounced than in CIDP.
Do MRI findings predict anything?
Not really. There's no clear link between having MRI abnormalities and the clinical presentation or the response to treatment. Also, the reliability of qualitative MRI measures, like just judging signal hyperintensity or enlargement, isn't great, and they can't reliably distinguish MMN from other inflammatory neuropathies, PMA, or even controls. Up to 23% of healthy controls might show some signal hyperintensity. Mild findings aren't definitive.
What about measuring things on MRI?
Semi-quantitative measures like measuring cervical root size seem to have better specificity and reliability, but their sensitivity is poor.
How does neuromuscular ultrasound compare?
Ultrasound is, inexpensive, non-invasive. Protocols can be done in about 15 minutes. It often shows enlargement of the intrascalene roots and brachial plexus trunks maybe in 68% of MMN cases. But more distally, regional or multifocal nerve enlargements are seen even more often, in 90 to 100%.
Where are enlargements most common?
Usually in the upper limb, the median nerve in the forearm or midarm is a frequent spot. Enlargement is more common in clinically affected nerves, but you can see it in nerves that test normally too.
So how should we use ultrasound practically?
Probably best to focus on clinically weak areas, but also do a quick screen of unaffected nerves. Comparing side to side is useful because MMN patients tend to have more side-to-side variability than controls.
Do ultrasound findings change with treatment or correlate with severity?
The abnormalities usually persist with treatment. There's no clear link between the ultrasound findings and disease duration, GM1 status, or treatment response. Focal enlargements might become more diffuse over time. And while the correlation with severity at presentation is weak, progressive hypertrophy might correlate with worsening weakness later on.
Does ultrasound correlate with conduction blocks?
Interestingly, no. There's a poor correlation between where you see enlargement on ultrasound and where the conduction blocks are found electrophysiologically. It suggests they might reflect different underlying processes.
Can ultrasound differentiate MMN from other conditions?
It's quite good at distinguishing MMN from healthy controls, and the measurements are fairly reproducible. While there aren't universally agreed upon criteria yet, ultrasound is generally better at separating demyelinating neuropathies from axonal loss or motor neuron disease, but less specific between different demyelinating types like MMN versus multifocal CIDP. One study showed it could differentiate MMN from ALS with about 88% sensitivity and 94% specificity using 10 specific landmarks. Another found 100% specificity just by looking at one nerve supplying the weakest muscle using specific cutoffs.
So helpful, but not perfect.
Exactly. No single ultrasound finding is specific for MMN. And remember, nerve size is affected by age, gender, BMI. Minor findings aren't conclusive.
How do MRI and ultrasound compare head-to-head?
They generally agree well when abnormalities are present. Ultrasound might actually be more sensitive for nerve root thickening. Plexus MRI can be normal in about 9% of cases where ultrasound finds issues. Some data even suggest MRI doesn't add much diagnostic value beyond good nerve conduction studies in ultrasound. Quantitative ultrasound of the median nerve CSA and cervical roots perform better than qualitative plexus MRI in some studies, with better reproducibility.
So the recommendation.
Ultrasound is increasingly seen as potentially the first-line imaging modality if you need supportive criteria, given its lower cost, potential for higher sensitivity in some areas, good reliability, and wider availability. Focus on weak areas, but screen unaffected nerves and compare sides.
Okay, let's synthesize this into diagnosis. What are the core clinical diagnostic criteria we should use?
The A&M and EFNS-PNS criteria really emphasize that clinical picture. Asymmetric, progressive, or stepwise limb weakness, crucially without significant objective sensory loss, beyond maybe that minor vibration loss distally in the legs.
And what rules MMN out? Exclusion criteria.
Unequivocal upper motor neuron signs, though slight hyperreflexia in an affected limb might be okay. Prominent bulbar involvement. Significant sensory deficits beyond that mild vibration loss, and diffuse symmetric weakness.
How are definite, probable, and possible MMN defined?
Definite MMN requires that progressive weakness in at least two different nerve distributions, plus definite conduction block in at least one nerve outside of typical entrapment sites. Probable MMN also needs weakness in two or more nerve distributions, plus either probable CB in two or more nerves, or probable CB in one nerve plus at least two supportive criteria. And possible MMN is weakness in two or more nerves, plus two or more supportive criteria, and objective improvement with IVIG counts as one or weakness in just one nerve distribution, but with definite or probable CB in one nerve.
What are those supportive criteria again?
Elevated serum GM1 antibodies, the T2 hyperintensity or enlargement on brachial plexus MRI, regional or multifocal nerve enlargement on ultrasound, mild CSF protein elevation less than 100, and as mentioned, objective clinical improvement after IVIG.
Makes sense. Now, the differential diagnosis is critical here, right? Misdiagnosis is common.
Very common, unfortunately. The most frequent misdiagnosis is motor neuron disease, particularly ALS. Diagnostic delays historically were long, 2 to 6 years. It's getting better, but still often too long. If there's uncertainty, referral to a neuromuscular center is really advisable.
So, key differentials besides ALS.
Well, ALS, especially flail arm variant or PMA, you need those careful EDX studies to find the MMN conduction blocks. Serum neurofilament light chain might help. It's more likely elevated in ALS. Hirayama disease, that's progressive asymmetric distal upper limb weakness, usually starts much younger in teenagers. Dynamic cervical spine MRI helps differentiate. Painless cervical polyradiculopathies EDX should show a root distribution, maybe with paraspinal muscle changes, not a peripheral nerve pattern like MMN. And then the other demyelinating neuropathies, CIDP, multifocal CIDP, MADSAM, HNPP. You use imaging, serology, CSF, and the specific EDX patterns to sort them out. MMN is mostly about the conduction block. Other demyelinating features are less prominent than in CIDP or MADSAM. HMPP has blocks mainly at compression sites.
Okay, that's a complex diagnostic landscape. Let's finally turn to treatment. What's the practical management?
Intravenous immunoglobulin, IVIG, is still the only FDA-approved maintenance therapy specifically for improving strength and disability in adults with MMN. Both EFN, SPNS, and ANM guidelines recommend it. First line, subcutaneous immunoglobulin, SCIZ, is also an effective option.
How good is the evidence for IVENG?
Several small randomized trials showed benefit, improving grip strength and disability measures. A meta-analysis supports this for strength and disability, although the evidence certainty was rated low. The way it works isn't fully clear, maybe neutralizing antibodies, reducing complement, modulating lymphocytes, inhibiting cytokines, lots of potential mechanisms. But interestingly, it doesn't seem to actually lower the GM1 antibody titers.
What's the response rate like?
Generally high, 70 to 94% respond. Improvement is usually quick, within 7 to 10 days, often most noticeable in the weakest muscles.
Can we predict who will respond best?
Some factors seem associated with a better response. Younger age at onset, fewer limbs affected initially, having definite conduction block, high distal CMA amplitudes, maybe abnormal brachial plexus MRI, and high GM1 titers. Having abnormal SNPs or high CSF protein doesn't seem to predict response. High CK might predict a poorer response.
And you mentioned patients with CB respond better.
Yes, generally patients with confirmed conduction block tend to respond better to IVE than those without.
So how do we manage suspected MMM patients without CB?
You need to be sure the clinical picture is really typical. Look hard for any other subtle signs of demyelination on EDX or imaging. And it's absolutely crucial to objectively assess the response to an IVIG trial. If they don't respond well, you really have to reconsider other diagnoses.
What's the usual IVIG dosing?
Typically start with a loading dose of 2 grams per kilogram given over 2 to 5 days. The benefit usually lasts about 4 to 6 weeks, so maintenance infusions are needed. Maintenance doses vary widely, from maybe 0.4 grams per kilo every 8 weeks up to 1 gram per kilo every 2 weeks. It has to be individualized based on objective improvement in strength and function, not just how the patient feels. And you need to periodically reassess if the benefit still outweighs the risks.
Any difference between IVG brand?
No major differences reported.
What about higher doses?
Higher maintenance doses, like maybe 5 grams per kilo per month total, can help some patients. There's some thought it might help prevent ongoing axonal degeneration and promote reinnervation. Ultra-high doses can even be tried as a rescue therapy for poor responders. But we need more research to know who benefits most from these higher doses.
Does the benefit last long-term?
Long-term benefit is reported, but that ongoing axonal degeneration is still a major issue. Responsiveness can decrease over time, requiring dose or frequency adjustments.
Side effects of IVU?
Usually minor headache, chills, nausea, muscle aches occurs in less than 10%. Serious ones like renal failure, heart failure, aseptic meningitis, or blood clots are rare, but possible.
Wait, what about subcutaneous immunoglobulin, SCI?
SCI has been used since around 2006, mostly as a switch for patients stable on IVE.
Advantages, disadvantages.
Benefits are fewer systemic side effects, more convenient home administration, potentially lower cost, patient autonomy, no need for IV access. Downsides: might be less effective than IVE for some, needs training, can have local injection site reactions.
Is it as effective as IVG?
Most studies show long-term SCI is an effective alternative for maintaining strength, often with better tolerability and patient satisfaction. A meta-analysis found it as effective as IVG, with about a 28% reduction in moderate or systemic side effects.
Does everyone do well switching?
Some patients might worsen on SCI and need a dose increase, maybe occasional IV boosts, or even switch back to IV sometimes within the first couple of years.
How is SCI dosed?
Usually given weekly. Absorption is slower and steadier than IVG, leading to less fluctuation in serum levels, higher troghs eventually. It takes weeks or months for levels to stabilize. The optimal dose conversion isn't totally settled. Most MMN studies used a 1-to-1 ratio from the previous IV dose per dink. Some use higher ratios, like 1.53 to 1. A 0.5 to 1 ratio seems too low. You can give large volumes by splitting doses over the week or using multiple sites at once. There's also facilitated SCI using hyaluronidase to allow larger volumes per site, which seems similarly effective but might have more local side effects.
SCIG side effects.
Most common are local site reactions: swelling, redness, soreness, itching, usually mild and self-limiting. Systemic effects like headache or nausea can happen, but are often transient. Rare blood clots have been reported.
What if someone doesn't respond well to either IVG or SCIG? Are there other options?
Options are pretty limited, unfortunately. Rituximab and cyclophosphamide are the most studied, but neither has proven efficacy in randomized trials for MMN. They might be considered as add-ons for poorer responders, maybe to reduce the immunoglobulin dose in responders, or as an alternative if someone is allergic or intolerant.
Tell me about rituximab.
It's an anti-CD20 antibody. Results in MMN have been really variable. One study showed some strength increase in IgM-associated neuropathies, including some MMN cases. Another found it didn't help produce IVIG dose despite depleting B cells. Case series are mixed. We really need proper randomized trials. Dosing is often 4 weekly infusions or 2 larger doses 2 weeks apart, then maybe repeat based on response or at fixed intervals. It seems relatively safe in MMN, so it's an option to consider for severe refractory weakness.
And cyclophosphamide.
There were early positive reports in patients who failed steroids or plasmapheresis. Later studies were mixed. Some evidence suggests it might improve strength, lower GM1 titers, resolve blocks, or reduce IVG needs. Sometimes used with plasma exchange for severe cases. Dosing involves 5E induction, then oral maintenance. But the side effects are a major concern: bone marrow suppression, infertility, bladder toxicity, cancer risk. Its use is very limited due to these risks and lack of proof it reverses established disability. It's really a last resort for severe cases refractory to IG and rituximab.
Any other immunosuppressants?
Interferon beta was tried in older studies, not much recent interest. Others like azathioprine, mycophenolate, cyclosporine, methotrexate have mostly been looked at as add-ons in small series. A randomized trial of mycophenolate added to IVG showed no benefit for reducing IVE dose or improving strength.
What about treatments that are generally ineffective or harmful?
Corticosteroids, oral or IV high dose, generally don't work and can actually make MMN worse. Plasmapheresis is also ineffective and might even worsen things or cause new blocks. Immunoabsorption seems ineffective too.
Are there any newer approaches on the horizon?
Yes. Complement inhibitors look quite promising. Several are being studied. Eculizumab, a C5 inhibitor, showed some subjective and objective improvements in an open-label study, though patients stayed on their IVA. The NT005, a C1 inhibitor, looked good in lab models. Impasaprubart, an anti-C2 antibody, also inhibited complement activation in vitro, and interim results from a phase 2 study have reported positive treatment responses. So that's an area to watch.
So summing up, MMN is definitely a complex motor neuropathy. It needs careful clinical assessment, thorough electrodiagnostics. Nerve ultrasound seems like a really valuable, accessible tool to add to the workup.
Absolutely. And while immunoglobulin therapy is the mainstay, we know its long-term effectiveness is often hampered by that progressive axonal loss. Early diagnosis and starting treatment promptly seem crucial.
And looking forward.
The development of those complement inhibitors is really promising, potentially offering therapies that could actually slow or halt the disease progression, which would be a huge step forward. Research into B-cell depletion like rituximab needs clarification, and maybe even CAR-I T-cell therapies could be explored down the line.
It really highlights the ongoing need for more effective ways to modulate the immune system in MMN to improve those long-term outcomes and quality of life for patients. This review provides a solid foundation, but keeping up with new research is essential. Hopefully, these insights are helpful as you evaluate your patients with suspected or confirmed MMN. As you go through your week, perhaps consider how integrating nerve ultrasound more routinely might fit into your diagnostic approach for asymmetric weakness.